is reflecting what was supported by that award. I'm actually from Canada, moved here a year and a half ago, and so I had never done Hispanic research before. I had never been in an area that had a predominantly Hispanic population, and so coming to this region and having this award and being able to start research and looking into Hispanic health disparities was really helpful. So I'm actually taking a look at fall prevention programs specifically aimed at older adults within the El Paso region. Now, if you're familiar with fall statistics, falls are actually the 7th leading cause of death in older adults. And that's right up there with myocardial infarcts, stroke, etc. So one of the big things that stands out for me in terms of falls is it's fairly preventable, considering some of the other biological issues that deaths are resulted of. When we look at the Hispanic population in the U.S. specifically, they're actually at the greatest risk for fall-related injuries and subsequent morbidity. It is actually 41%, which is 10% higher than other ethnic populations in the United States. And one of the other statistics was there was about 500 falls a year between the years 1990 and 1998. And when you look at the region of the U.S. itself and the states specific to where these falls are occurring, the 2 highest states are New Mexico and Colorado. Okay, so New Mexico actually is 67% higher than the rest of the U.S. in terms of fall rates, fall-related injuries. So it is very clear that we need fall prevention in the El Paso region, being so close to that very high New Mexico state and having a similar demographic. So let's talk a little bit about falls. Falls are not a simple problem. In fact, they're very, very complex. So when trying to address falls, you come at it from many different areas. We have 3 major categories of factors. We have extrinsic factors, which are typically environmental. Okay, they have to do with whether there are rugs, obstacles present. The intrinsic factors are the really tough ones, because they have to do with physiological issues, musculoskeletal issues, and any psychosocial issues. So if you've heard of fear of falling, those sorts of intrinsic factors. And then the third one is also falls predict falls. So if you've had one fall, chances are you're going to have repetitive falls after that. Interestingly enough, when you look at why falls occur, 35 to 47% result from an obstacle, and 27 to 32 result from a slip. So you're talking upwards of 79% of falls that occur are due to something, either an obstacle or a change in the surface on which you're walking. And this is what we call problems in adaptive postural control of motion. Your inability to be able to adapt to those things in your environment, such as changing surfaces on the ground where your feet are going, okay, and slipping, or possibly tripping over, say, that sidewalk or obstacle in your way. Now, taking a look at what's recommended across the board, the American College of Sports Medicine recommends strength, endurance, flexibility, training, static balance exercises. The CDC recommends, again, physical activity, routine eye exams, medication, education. However, when you look at the recommendations from these 2 specific entities, you find that they do not address the complexity of adaptive locomotion, which is responsible for 79% of those falls that are occurring. And so if you take a look at what's going on here, if you think of falls occurring and then resulting, there's a reduced activity, which goes into the whole, okay, they need to keep up physical activity. You could also think that, all right, if they're not doing things physically, they're also potentially losing that neural proficiency. Okay, if they're not using their system, okay, they're going to lose those pathways that control the system. We're talking about the motor control of movement. And we're also losing sensory processing efficiency. If you're not getting up and in your environment, you're losing the ability to be able to visually detect things that are going to be problematic. So that's what we're going to look at here. So, okay, the purpose of this study. So we wanted to look at exercise programs to help with falls prevention. And so we specifically wanted to address physical activity, we wanted to address balance, and we wanted to bring in something that hasn't really been looked at before, visual training. Visual training for the purpose of obstacle avoidance and adaptive locomotion, because it is about 79% of those falls. We hypothesized that exercise programs that had agility components, which have been shown before, would benefit. But on top of that, that program that included visual training would result in the highest improvement on some of these measures that we use to see how mobility is in older adults. Okay, so our methods, we have 49 subjects total by the end of the program. They are 65 years and older. They were independent community living El Paso residents, okay? So these are people within the community that drive, that walk around, so they're not your sort of really, really frail individuals within supportive care homes. The participants were required to have consent before starting the program. We actually had 3 main groups. Okay, our first group followed the ACSM guidelines, and this served as sort of our control. Okay, this is what the guidelines recommend. What is their improvement on our measures of mobility going to be when you take into consideration the actual recommendations? Our group 2 is just an agility group. Okay, so we're going to take the recommendations and we're going to add agility and see how that improves their performance on these measures. And then our third group was our visual group. Okay, so on top of the recommendation on physical activity, they did some agility. We also had them do some visual training. So we're looking at the differences of these 3 things coupled. They trained for 90-minute sessions 2 times a week for 12 weeks. Okay, so this occurred over the fall semester. The variables that we took a look at to assess their performance, we did an obstacle course, okay, and this simulated everyday activities, and I'll show you that picture of that in a second. And then we also did other clinical tests of balance. So if you're in the clinic, you're familiar with the timed up and go and the functional reach. And we also did some other senior fitness tests, which I don't have up here because I didn't want to keep going. This was our obstacle course. So as you can see, it had sort of 3 arms. They started and ended in a seated position. They went towards the right, over and ducking under. They had to go through columns. They had to pick up a weight. They had to go up and down stairs. They had to place a weight down. They then had to walk along this balance beam here, which was 3-inch foam. Okay, so in a Romberg position, so this is sort of our balance component. They walked around this column and sat back down. So you can see that this obstacle course has a lot of those components of everyday activities. That's just a picture of each of these. So this is the one arm here with the over and under. Here's the columns they had to weave around, the stairs with the weight, and here's the foam balance beam there. Okay, so taking a look at our obstacle course results, this was course time. So we timed them on the course, we timed them twice and took an average. Okay, we did this pre, post, and final. And when you look at the difference between their baseline measure at pre and their mid line and their final and their pre, we see that there were significant improvements across all groups. Okay, so this is a difference. So the more in the negative, the more they improved. Okay, so there was no group differences, just a general significant course time improvement across. So this is good. They're getting faster. They're able to take the obstacle course better. The interesting result came when you looked at the actual contacts with obstacles. So okay, they're going through the obstacle course. How many times are they actually hitting these things as they're going through? Again, looking at the difference between midterm and baseline and post and baseline, what we saw is that the visual group actually had the greatest improvement in obstacle hits. Okay, so they were hitting things less as they were increasing their time. They were getting more accurate, okay, but they were able to complete the course a similar time. We saw a moderate improvement, but not significant, in the agility group. And we actually saw an increase in the control group. So the control group were just hammering through that obstacle course. But again, they didn't really have that agility and visual training. Taking a look at a combined variable, so we thought, okay, let's take a look at time and hits together. So we took a look at that combined to get an overall picture of what was going on. You see that the visual group is improving the most compared to the agility and control. So just in general, a summary of the results. We actually saw that the visual group significantly reduced their obstacle contacts while they were able to improve their time. And they had the greatest improvement on performance in the obstacle course at 22% in comparison to the other 2 groups. What does this tell you? It tells you that visual training for the purpose of obstacle avoidance might be critical in the ability to be able to
successfully, adaptively move in your environment, in an environment that is relevant to your everyday activity. Where are we going with this? This is the first time that I've taken a look at this in this area. And so now I'm going to take this information and move further. What other sorts of programs can we look at? What other sorts of visual training can we look at? I want to go into the community, and I want to get those frail individuals, those people who have had more falls, and take a look at it, trying to improve them. One other interesting thing that I want to look at is, why do Hispanic older adults have the highest fall-related injury rate? What is it particularly about this population? And do we need to construct programs specific to this population? Nobody has looked at that. Nobody knows why the rates are like that. And so I would like to now go into that as a transitioning faculty member into Hispanic health disparities. Okay, so that was brief, I think. Thank you. Any questions?
There will be 3 minutes for... There will be 3 minutes for questions and answers after each speaker. And also, the first 3 speakers will speak. There'll be a break. The next 3 speakers will speak. There will be a break. And then all 6 speakers will also be behind these 2 tables here, and they'll serve as a panel. So there'll be an opportunity to ask speakers questions besides this 3-minute period.
Okay, I'll start over here. Sure.
Have you thought about how to ferret out why they fall so much? Are you going to try qualitative therapy or something?
That's what I'm hoping now, yeah. So having gone over and writing up this sort of information and going through the literature, seeing the statistics and not finding one paper that's actually kind of gone into a Hispanic community and said, okay, why are you falling? What are the reasons? Is it chronic conditions? Is it environment? Is it knowledge of falls? And so sending like a survey out or something like that, yeah.
Have you thought about home visits and sort of accompanying the person like all day?
Something that would be great, yeah. Again, it's an idea that I have. I am not familiar in that type of research, but I think what I need to do now is team up with those people that are very familiar with home visits and the community partners, and just trying to get out there and just into the community and see. Absolutely. Joe?
Can you talk just quickly about how you implemented the weeding intervention? Did they do it in the lab? And how did they react to it? Did they enjoy it? Was it fun?
Absolutely. Yeah, I breezed over the weed, didn't really even talk about it for the sake of time. So the WE intervention for the visual training group, they came in twice into the biomechanics lab, which is just adjacent to where they were doing their strength and conditioning training. And so they played 6 rounds of 2 games on the WE Fit. One was a soccer heading game where they had to dodge soccer balls. The other one was a penguin tilt where they used their balance to tilt this iceberg for a penguin. They loved it. They absolutely loved it. They wanted to do more. The groups that later found out that they hadn't done it, like so at the end of the study when everybody got together, they were like, you were doing the WE, why couldn't we do that? And so it's something that they would like to continue with. In terms of my thoughts for that, it was, they were so happy playing, they loved coming. This would be great for populations that have like depression, going into those assistive care homes where they need something stimulating. This will get them doing it. And my other thought being, what about like an Alzheimer's population too? Taking a look at that as well, so getting those cognitive processes going. Yeah. One last question? Yep.
Have you thought about looking at comparing them with other age groups?
Like in terms of younger adults or anything like that?
Yeah, younger adults.
Good point. Like just take a control group. We could. Generally, we've just tried to stay with the older adults just because there is a lot of information in terms of, in general, older adults and what's going on there and seeing their improvements within that group. They're quite different from young adults right off the bat. So we don't do a lot of those comparisons a lot of the time. Yeah.
And what age do people start falling a lot?
65 and over is generally the older adults, but if you look at the later years, so 70, 80, 90, the rates kind of do this. So towards that older adult. Yeah. Okay, I think that's probably my 3 minutes, so thank you very much.